Now, what about the toxicities of this regimen? There were more adverse events noted in the ramucirumab arm, but overall, these toxicities were as expected based on what we already knew about ramucirumab and readily managed. So in particular, patients treated with ramucirumab had high rates of hypertension, and hypertension is a well-known class effect for drugs blocking VEGF receptor 2 or VEGF receptor. And that was typically managed with just antihypertensives as well. There was an increased rate of proteinuria. Now, proteinuria is something that is picked up on lab tests and also happens with VEGF or VEGF receptor inhibitors. It's not something that patients can typically notice. It really just has to do with the laboratory testing. There were some adverse events of special interest. There was a bit more bleeding. Most of this was epistaxis or nosebleeds that happened. This is a side effect that also happens with VEGF inhibitors, thought to be related to the mucous membranes getting dried out a bit in the nasal canal. Again, this is not something that's limiting. It's typically readily managed. But those were the primary adverse events that occurred in an increased rate in the ramucirumab rates. There was slightly higher rates of diarrhea, acne, and myelosuppression, but none of those were significant difference or clinically significant differences between the two. So overall, the adverse events were as expected, readily managed, something that we have experience dealing with because ramucirumab is a drug that's been FDA approved for a long time, and we have a lot of experience with these side effects. In fact, my experience with ramucirumab has been consistent with what's been seen in the Relay study. You know, I've had a lot of experience using it through the years in combination with docetaxel based on its earlier FDA approval. And in general, I find that patients can be readily managed. Hypertension does occur occasionally, and sometimes we have to start additional antihypertensive regimens. I commonly will use calcium channel blockers or beta blockers in this situation. But in general, patients do very well, and it's exceedingly rare, at least in my hands and in the Relay study, to have to stop the ramucirumab because of adverse events. So that's the safety and adverse events, and I think in general, the Relay regimen was well tolerated overall and readily managed with predictable and known adverse events. There were an increased rate of adverse events in the treatment arm, but again, in the context of the dramatically improved overall outcomes, I think really favorable benefit versus risk ratio in that setting. Now, what about the safety and efficacy of other treatments out there? Well, the other treatment that I would use most commonly would be Osimertinib, based on the first-line FLORA study. Osimertinib is a very good drug in the first-line setting for patients with typical EGFR mutation. The median progression-free survival with Osimertinib by itself is 18.9 months, as compared to the 19.4 for the Relay study. As compared to erlotinib or the first and second generation drugs against which it was tested in the FLORA study, erlotinib or gefitinib, Osimertinib has a favorable safety profile. It's got slightly lower rates of acne. It still does have diarrhea, but the rates are a little better overall. And in general, patients actually do very well with Osimertinib. I think in particular, the lower rates of skin toxicity make this a particularly appealing option. So Osimertinib absolutely remains an option. And I would typically go with one of those two regimens, Osimertinib or, if FDA approved, erlotinib and ramucirumab, as compared to the other regimens. I would particularly go with Osimertinib with patients who present with brain metastases in the beginning because of the well-documented efficacy in the CNS for osimertinib based on a number of studies. So that would be an option that would push me towards osimertinib as opposed to erlotinib and ramucirumab. But I would certainly discuss both options with the vast majority of patients who present with the typical EGFR mutation. Now, I've mentioned already that ramucirumab adds significant efficacy on top of erlotinib as seen in the RELAY study. So would it add similar efficacy if we combined ramucirumab with osimertinib and really put those two things together? And I certainly think that's an extremely promising regimen. As part of RELAY, they've opened an Arm C where they're actually looking at that combination. In my group, we've opened a multi-center study. This is led by Xining Li at MD Anderson, testing ramucirumab and osimertinib versus osimertinib. There we're using every 3-week ramucirumab. And there's similar studies testing VEGF inhibitors with osimertinib. For example, bevacizumab with osimertinib is also being studied in randomized trials. So I think both the preclinical rationale and all the clinical data so far strongly supports that VEGF inhibitors can offer benefit to patients with EGFR mutant non-small cell lung cancer. And RELAY is the first randomized phase 3 that achieved its primary endpoint in terms of PFS and showed a really striking benefit. Now, is there going to be an overall survival benefit? Well, the overall survival data thus far is not immature, so we're certainly waiting to see the results of that. But the results we have seen so far really do show a striking magnitude of benefit, 7-month improvement in progression-free survival with ramucirumab plus erlotinib as compared to erlotinib alone. So from my perspective, and given that patients who start with that regimen often can then go on to osimertinib later, so you actually can have 2 lines of an EGFR targeted therapy. Certainly, from my perspective, this becomes an appealing first-line option that I would offer to the vast majority of patients who present with an EGFR exon 19 deletion or an L858R exon 21 point mutation, the so-called typical mutations.